what I hope to achieve here at Sunnybrook. As MJ alluded to, I did my residency training here. I also did my undergraduate training here as well in engineering science with the biomedical stream. This sort of kind of ignited my interest in devices and novel technologies in neurosurgery. As in exploration of focused ultrasound, it was really Dr. Lipson who introduced me to this technology. I think as a technology, there has been a long interest in using focused ultrasound for intracranial applications, but it has traditionally been limited in the fact that the brain is inside a skull, which is difficult to penetrate for ultrasound. So with the turn of the century, with advances in neuroimaging and transducer design, ultrasound has really been re-explored in neurosurgery for brain applications, in that we can now correct for the aberrations created by the skull to allow transcranial applications. So my work initially started in HIFU, or high intensity focused ultrasound, using an Insight device, which is a hemispheric design. The transducers, over 1,000 of them that are aligned in the helmet of this device. And it's sort of like a magnifying glass, with the ultrasound beams are converging into a single spot in the brain to create heat. And this was a low hanging fruit application for this was in essential tremor, which is a type of movement disorder. Patients have very disabling tremors that impact their action, their posture, and patients can't eat, they can't drink, they can't really even take care of themselves. So by creating a lesion in the thalamus of these patients, they immediately have an improvement in this tremor. So Dr. Lipsman and among others were instrumental in doing the pivotal study that led to the very rapid clinical approval and adoption of this technology for these patients. While prior to this, patients were getting more invasive surgeries through implantation of electrodes to heat up the tip to create that same lesion. Now they can do it without even getting, without opening the skull. So my earlier work in my research was looking at the long-term outcomes, as well as proving that it is cost-effective in the patient population in Canadian insurance system. So as I mentioned, there's an increased interest in using ultrasound for brain applications. And really around the 2016 mark was when ultrasound, we were able to show that we can increase the blood-brain barrier. And that's when I started my research with Dr. Lipsman. I was very lucky to be involved in the very early phase trials demonstrating this was a feasible and safe approach in patients. And I'll just skip some of this. And why do we care about the blood-brain barrier in terms of why do we want to try to use focused ultrasound to disrupt the blood-brain barrier? The blood-brain barrier is the entity that sits in the capillaries in the brain. It prevents large molecules from crossing into the brain. So in doing so, it limits a lot of drugs that are in development from passing through and having a good effect into the brain. And it reduces the efficacy, not only reduce the efficacy, but potentially to off-target effects, as you would require increasing concentrate to achieve the same effect, and you resulting in off-target side effects for patients. So there are many ways to improve drug delivery to the brain. And one way is to traditionally through convection enhanced delivery. So that's basically inserting a catheter into the brain and hooking that to a pump that will continuously inject a drug through, and the drug will permeate through the brain through a diffusion process. There are other ways, like post-surgery, you can implant wafers like gliadel to have the drug that's impregnated with drug, and slowly it would also diffuse through the surgical cavity. Other ways to modify the blood-brain barrier before the exploration of focused ultrasound has been in using intra-arterial mannitol, which is a way of disrupting the blood-brain barrier through intra-arterial injection. This is an interesting way, but one of the limitations of this that you have to have the patient go through a catheter angiogram. It's quite an invasive procedure to have a patient go through it over and over again. So some of these limitations, the attractive focused ultrasound, it overcomes some of these limitations that are inherent in the traditional drug delivery techniques. There are many studies prior to when I began my PhD work. Many studies have been done in showing that how focused ultrasound BV opening works, and how it can be safely achieved in animals, and been paired with many different drugs that have been shown to increase the concentration of it with ultrasound. So how does it work? It works by mechanical disruption of the components of the blood-brain barrier. So we would inject a subject with intravenous microbubbles, and the microbubbles would circulate through the capillaries. And with the exposure to ultrasound, the bubbles oscillate under stable cavitation. That mechanical force exerted on the vessel wall causes a breakdown of the tight junctions and other blood-brain barrier processes. The interesting and advantageous aspect of ultrasound BV opening is that not only can be done transcranially, we can selectively target different areas of the brain. On the left, this is an animal study that was done in a non-human primate. It basically was a feasibility study showing that you can increase the blood-brain barrier by showing that contrast enhancement in these areas in various regions of the brain in a very selective fashion. And you can modulate the blood-brain barrier permeability by different factors like the ultrasound dose, microbubble dose, so concentration of microbubbles in the area of ultrasound exposure. And also the tissue properties play a role in this as well. As you imagine, with greater vessel density, you have more microbubble concentration in the area. So on the right is a study that was done also in animals showing that by increasing the acoustic pressure, you can get increasing concentration of trastuzumab in the tissue of target tissue. Again, when I began, I surveyed the literature and I found many studies showing different regions of the brain could be disrupted by the blood-brain barrier, and also importantly, various animal models were tested at the time. So this is important because the skull is a really important factor in whether ultrasound can be accurately delivered through to the brain, and the morphology of a rodent skull is very different from that of human skull. So the closest that we have typically modeling human skull are porcine, and these large animal studies were really important to show that we have increasing confidence that we can safely achieve this in human patients. So I'll skip through these slides. Just one of the first indications will be tested in patients with glioblastoma, given, as you all probably familiar with, these are patients with very poor survival, and despite a lot of effort to try to improve their outcomes, it's been a very tenacious, challenging to treat disease. And we think one of the reasons for this is the restricted blood-brain barrier or blood tumor barrier that either limits good penetration of chemotherapy or systemic therapies, as well as the exposure of the body to the tumor antigens that allows an immune reaction to the tumor. So as I mentioned, one of the first patient population tested was in patients with glioblastoma, and this was a study led by Dr. Meng Price. The primary objective of this study was to test the safety and feasibility of focused ultrasound BV opening in the tumor and in peritumor tissue. And patients had these procedures done with oral temozolomide prior to surgery. And the patients were observed for any adverse events for 3 months. And the device that we used was a focused ultrasound device made by Instantec company, which is a hemispheric array. And these were 5 patients were recruited to the study, and this was the initial result. So just to kind of explain what we're looking at, this is a T1 with GAD MRI. And a faint area of enhancement, this was the tumor, and beside the tumor was a 3x3 grid that you can see that was made by the device. So what the ultrasound machine does is that when we place the target, it sonicates sequentially one target next to each other. We place these subspots on, and as a result, you see greatest enhancement in the focus spot, and as a result, you see 3x3 spot early on in these studies. So nowadays we're able to achieve more homogeneous BB opening and larger volumes. So I'll show you some of the results later, a few slides. So this initial experience led to our recently published phase 1/2 trial. This was a trial that actually had the same protocol in several different sites, and was the combined analysis was recently published. So basically the idea is that we would overlap focused ultrasound BB opening during the first day of every adjuvant TMZ cycle. So after initial chemo and radiation, if patients are doing well, they would be recruited to this study. If they're getting adjuvant TMZ, and the first day when they take the pill, they would also come into the hospital, be admitted, and get the BB opening procedure. And these were some of the initial results. So just example of 2 patients who had one had a prior surgical resection, another patient had a biopsy because of a deeply seated tumor, and we would sonicate in the tissue around the surgical cavity. You can see increased enhancement in these regions after focused ultrasound exposure. So we published these initial studies, try to demonstrate some of where some of these tumors are located. Many are superficial, but some are also deep. And we were able to show that we can get increased gadolinium enhancement in the sonication target. I try to also quantify this in a more quantifiable way. At the time, the ultrasound system was getting more sophisticated. We were then able to get ultrasounds, acoustic signals back from the machine as we were sonicating. So when we did the initial few patients, we would sonicate and sort of manually try to figure out what ultrasound dose to use. And as the system became more sophisticated, it's able to then receive information back during sonication and modulate the power depending on the feedback. And this really sped up how the volume that we could sonicate. So you can see, as opposed to 3x3, we were treating much larger volumes in these patients in a much quicker timeline. So the results that were published recently was the 34 patients that were recruited across 5 sites. We were the largest recruiting site. And the study started all the way back in 2018. Just showing some of the patient demographics. Mainly for the patients who were in the study, they suffer mainly from side effects from the frame placement. So as it stands now, the current device still requires a frame to be placed for patients, and that's the way we immobilize the patients during these procedures. It's basically a remnant of the thermal ablation setup that I showed you previously. You can imagine if we're trying to make a lesion in the thalamus, we really want to be very precise. But the same concept may not really be true for BB opening. I think we're treating much larger volumes, and there is more leeway in terms of the precision, spatial precision we require. But just in terms of the technical setup, so patients still require having a frame placement. During the procedures, you can see a lot of pin site pain, pin site numbness, and swelling that were attributed to the placement of the frame. And in moving forward in our technological development, moving away from having a frame placed, as well as the hair shave, that is again also not necessary for BB opening procedures, given it's a low frequency device as opposed to high frequency or high intensity device where you really don't want any micro bubble or air bubbles to be trapped along with the hair follicles. There's a lot more tolerance for this in low frequency applications. So these are 2 main factors that are one of the main challenges of recruiting patients and retaining patients in these studies are something that really we can try to do without in the future. So interesting, a very encouraging encouraging data from these pooled patients. Where interestingly, they were able to combine with a match control cohort and show that indeed patients who had this procedure had a very encouraging overall survival, and was statistically significantly improved compared to the matched control. And as a result of this, we have recently published data. We have a lot of interest generated in participating in our current ongoing trial, where we're trying to overcome some of these technical limitations, including the frame and the hair shave, as well as the fact that patients have to go through, be in an MRI machine. There's a lot of interest in participating in our current study to try to overcome these limitations. Moving on to another pathology. So we are just looking into publishing this result, this trial as well. This is our collaboration with with the group at SickKids, looking at patients with DIPG, which is diffuse intrinsic pontine gliomas. So again, very terrible disease with very poor prognosis. This again is a feasibility study showing that we can disrupt the blood-brain barrier in a more eloquent location, probably the most eloquent location in the brain, which is the pons or brainstem. So you can see a patient here. This patient's brainstem is very expanded as a result of the tumor. And it was a dose escalation study where we would bring the patient over 3 cycles with sonicate 50% of the tumor, then 75%, then 100%. And by this time, when we were doing this study, we had learned so much more about BB opening that we can do this quite efficiently. And you can see a very clear BB opening that's more homogeneous. And as a result, this patient in general tolerated the procedure well. Some patients had a transient worsening of their pre-existing deficit, which we weren't able to associate with any radiographic changes like hemorrhage or swelling. And all the patients had returned to their baseline after a short period of time after these procedures. So we're excited to hopefully publish this result soon. So another study that I did during my PhD, which was really important, was to show that the drug can actually get through. So in all these studies I showed you, we were looking at gadolinium enhancement as a surrogate for drug penetration to the brain. But this may not actually be true because drugs are different in properties, they're different in size, different in other molecular chemical properties. So can we get something as big as, say, trastuzumab, which is a monoclonal antibody, through the blood-brain barrier if we were to combine it with ultrasound? So we were able to work with a very great collaborator at U of T who specialized in radio-labeling different compounds. And he had, at the time, radio-labeled trastuzumab with indium 111 as well, that was able to allow us to characterize the location of this drug in vivo. So we were able to do some SPECT studies with the patient injected with this compound before focused ultrasound, sonicate, and then wait a few weeks for the drug to wash out. Then do the same study with ultrasound exposure at the same time. And we showed through these nice studies that we can increase the drug concentration in the sonication target very definitively, which is, I think, at the time, a very important thing to show. And we have 4 patients that was published in this study. And we show that approximately about a 2 to 3, and in some patients 4-time increase in the drug concentration in these patients. This is something that we plan to continue on further, as Dr. Riley's also was able to, he's also provided a kit that we can radio label pembrolizumab. So something we're interested in the near future to test this with ultrasound to see if we can get more drug through after FUS. Switching gears a bit to liquid biopsy. So the other aspect of BB opening in getting more drug through is we're interested to know if more tumor biomarkers will shed through into the bloodstream after BB opening. And I won't belabor why liquid biopsy is interesting or important but to show that it's actually it's challenging for brain tumors for a couple of reasons. One is that we think it's the blood-brain barrier that limits these markers from shedding. This is an early study that showed in various different cancers, it was gliomas who had the lowest ctDNA in circulations compared to all these other systemic cancers. Another challenge in liquid biopsy for glioblastomas, for instance, particularly, is the heterogeneity of these tumors. So one area of the tumor may be very different from another place. So to able to spatially sample different areas of the tumor without a surgical biopsy, for instance, would be potentially a clinically important approach. So people have looked at using ultrasound for different cancers. This was a study in an animal colon cancer model that showed an increase in biomarkers, another study in prostate cancer model. We were interested in looking at this in our first 9 patients that were recruited into the phase 1/2 study, and we show that after BB opening, we were in fact able to consistently increase cfDNA concentrations post BB opening. We track that in patients over different cycles, and there's a consistent over 2 times increase in cfDNA concentration. We were able to find a weak correlation with BB opening volume. And we found that most of its cfDNA increase were in short fragments, we think likely due to ctDNA shedding. So another interesting variable that we found is that in patients who had a stable disease throughout their temozolomide cycle, as opposed to patients who had early progressed and had to exit the study, for instance, they had a lower increase in their cfDNA enhancement. And this is something that has been further developed on by the combined group of 34 patients. They found that in patients who had greater enhancement in their cfDNA concentration, these were patients that had progressed early as compared to people who had more stable disease. So this could potentially be a biomarker that will be explored in future studies to try to predict who will at higher risk of progression versus those who had stable disease. Finally, just to talk a bit more about different clinical prototypes, we here use the hemispheric design, but there are other different focused ultrasound designs that are used elsewhere that are very popular and gaining tractions, and there's some phase 3 clinical trials, for instance, in SonoCloud, which is an implantable device for patients with glioblastoma, Sonobird clinical trial. Basically, this design is the transducer is placed on a mesh, which is implanted like, so when we do surgery, we have to take the bone flap out. And instead of replacing the bone flap, they would replace it with transducers. This transducer has a hub that is covered with the skin flap, but after surgery, when patients come to clinic and get their chemotherapy, they would be hooked up with a pin that powers the transducers, and they're able to create BBB opening at the bedside. So the advantage of this system is that it's kind of user friendly. Patients don't need to be in an MRI. They can be powered up anywhere, like in an infusion unit. And it doesn't involve a lot of devices around the patient. Another setup is the neuronavigation based system, which is a transducer with fewer elements. So you can see it here that is movable in space by the operator. And it's connected with our neuronavigation, something very similar to our neuronavigation system, and it uses basically infrared markers to be able to tell where the transducers are in space. So these are some other basically commercially available devices that each have their own pros and cons. We currently here uses this, but they're hopefully we'll hear more and more about the other prototypes as we are sort of in the arms race to try to see which one develops with the most data in the future. So, and in terms of patient clinical flow for this, as I mentioned, patient right now are unfortunately still have to wear a frame, which we hope will be, our current technical work is focused on being able to develop the device that does not require a frame. When patients, after patients have a frame put on, this plastic sombrero goes around their head. And this is done so that when the patient's head is hooked up to the helmet, it keeps the water from leaking out around the patient's head. There are MR coils also designed around the membrane that allows us able to do better MR images during the sonications. Prior to this, we were using body coils, so some intraoperative planning images were not as nice. So this allows to get more clearer, better intraoperative images assessed for instance, effectiveness as well as adverse events. So after patients are in the system, they get intraop images to help us align the patient and also plan our targets. And once the targets are placed, we inject the patient with microbubbles and deliver the sonications, during which you get acoustic feedback and the system modulate the power. And we can assess for BB opening with injection of gadolinium. And depending on what we see, we can kind of repeat the whole thing again to achieve greater volumes of BB opening. This is what the system that we're currently using developed at Sunnybrook with Dr. Hidden's group. This device is using about 3 times the number of transducers as our previously used commercial prototype. And the goal with this, again, is to try to develop a patient-specific helmet that will allow patients to be getting the treatment outside of the MRI without a frame and without significant hair shave. So just some preliminary images that were of a patient that is undergoing a current study. This is a patient who, apologies, I don't really have, it's not a really good, just catching the edges of the tumor. This is a patient who had a molecular GBM, so a grossly non-enhancing tumor. And we sonicated in and around the tumor in these areas. And you can see very homogeneous BB opening right after the ultrasound delivery. And the next day, kind of recovery of the BB permeability in these regions. So I think we have come a really long way, but still a lot of improvements we need to make on the device to make it more clinically useful and adaptable. So kind of talked a lot about ultrasound, but I do other types of research as well. And I work with collaborators who are experts in peripheral nerve tumors in developing ultrasound to as a novel strategy to treat patients with difficult to treat peripheral nerve tumors that are not surgically resectable, for instance. I also work with SRI scientists in imaging to try to develop novel imaging markers, as well as blood biomarkers. So I'm interested in hearing from people if they want to collaborate or learn a bit more about my research. And just will speak briefly more about some of my efforts in tumor biobank. I think is relevant for this audience in that we restarted the Sunnybrook tumor biobank this year. After Dr. Meng Price. Dr. Meng Price had been managing the old biobank, but it's a citywide biobank that is not actively recruiting patients anymore. There's still 400 to 500 samples in that biobank. So if there's any scientists who are interested in studying different kinds of brain tumors, feel free to reach out. But we're not actively recruiting into that biobank. We have I have with Dr. Hubert Sui have looked at, we have opened a Sunnybrook institutional biobank, and this was done earlier this year, and we have worked through with anatomical pathology and in storing snap frozen tissue, whole blood samples, and plasma samples, as well as CSF, sorry, typo, CSF. And we're able to do fresh tissue diversion for scientists who are interested in getting tissue right away from the OR. And so far, we have collected 23 patients, mainly because we're working through kinks in the whole process, but also because we're currently prioritizing more rare tumors. But I think with increased collaboration, we will be looking to ramp up the number of samples collected in this biobank in the next year. I myself have been working with Dr. Maggot Gubran in looking at 3D spatial histology. As many of you are aware, histology traditionally is in 2D. So if you get a surgical sample, you would fix it in formaldehyde, and then you would put it into a block, and you would section it into very thin slices, stain it for a marker of interest, and then look under a microscope. One limitation of this technique is that you lose the 3D architecture of your tumor sample, which can be very complex in the case of glioblastoma. And Dr. Gubran has been working on a technique to optically clear the tissue. Basically, what that means is if you take brain, which is made, that optical density is mostly contributed by fat. So if you're able to take the fat out of the brain tissue, then you get an optically clear specimen. So hoping the next slide will show this. Yeah. So this is the jars of a single. This is a single jars from a patient who had low-grade glioma resected. So, and this process can take over a month of different steps of agents that removes the lipid away from the brain. And over time, you get more and more optically clear tissue. And then we stain it with traditional antibodies that are with secondary fluorescent markers. And depending on what you want to see, you can then scan this tissue in 3D. And the idea is that if we are able to scan it in 3D, then we can reconstruct some very complex processes like the vasculature tree in 3D and use deep learning algorithms to basically look at the complexity of these processes in a more comprehensive process. So this is a project that is I think very cool. I don't think this is happening in many other places. This technique has traditionally been used in neuroscience to look at brain circuits, but I think it has a lot of potential to help us understand the spatial heterogeneity in complex tumors like glioblastoma better. So yeah, so that's the end of my presentation. Just like to thank the people I work with, from my family, and everybody who's been in there while I've gone through my training and my PhD research, and my mentors who obviously made this happen for me. And I thank again for all the collaborators.
Great. Thanks so much for this really wonderful overview, Ying. I know you touched upon so many different things, and I feel like, we all learn something new every time we see one of your presentations. I'll open the floor now to questions. If you want to either type it in the chat, I think you can also just, turn your camera on, unmute yourself, or raise your hand, whichever way you prefer to ask your question. Maybe to get things going, I'll start off with maybe just a general question for you. When it comes to FUS and drug delivery, is there a particular area right now that you're most excited about? Like, where do you think we should be taking this next in terms of next types of trial or next types of tumors or drug types to be looking at?
So I'm very excited in how focused ultrasound be opening interface with immunotherapies and kind of immune recognition of tumors. So I think this is an aspect that there are a lot of study done in preclinical models, but not quite enough in clinical trials. So, the effect size that we're seeing in our phase 1/2 clinical trial is very encouraging, and I wonder if some of that is contributed by kind of an immunomodulation that FUS is providing for these patients. So I'm looking to study this aspect of our trials a bit more, and potentially a trial that combines focused ultrasound with immunotherapy for patients.
Because you guys had been looking at that for a brain met study too, right? Like with the Pembro and FUS in lung cancer. Do you guys have any early data to suggest interesting results?
That's a great question. I think we had 1 or 2 patients in that trial, but so far we aren't actively recruiting that study, and I won't be able to tell you exact reason why. But that study is more actively recruited in Miami. So I'd love to know a bit more about that actually. But we have looked at it in a preliminary way in patients who had in the glioblastoma study, in patients who then underwent surgery. But it was just not a simple task, because many of the patients had surgery later on down the road, and then it's a question what kind of markers you'd be looking for, and there's no comparison. So it's difficult to it was a difficult aspect to study in the study that was published.
Right. Okay, and let's see if there's any other questions from the audience here. I see Kasha's on and Deepak's on too. James, any questions? Oh, Deepak has a question. Go ahead, Deepak.
Okay, thanks. So I was more interested in actually the liquid biopsy aspect of the presentation. So like, I guess one question is there any studies that have been done to see how it affects the biomolecules that are, being released? Like, does it actually modify the biomolecules, break it down, something like that?
That's a good question. I don't think so. There had been one study that was done in, I want to say, 5 patients who were on the way to get surgery. And that's the only study I know so far that demonstrated actual mutation calls from the samples that were collected after focused ultrasound. And I want to say that the results weren't like a slam dunk. It wasn't like 100% sensitivity in the patients who had blood collected. I think when we are looking at our samples, it was sort of not planned to do liquid biopsies. These are patients who had surgery, they had pre-treatment. I think, we obviously did finish a liquid biopsy study where it was a multi-center study, and the samples were sent to a central lab to look at for the blood collection and the tissue samples. So I don't know if that's something they're looking at. I don't think so. I think they're more looking at sequencing and mutations and things like that. I don't know if they're, does that answer your question? Sorry. Are you looking to see if tumor markers are modified with opening?
Yeah. May not, yeah. So yeah, I don't know if so I think it's an open question to know, what's the integrity of circulating DNA or RNA under, ultrasound manipulation, right? Or if you're looking at specific proteins or other biomolecules, metabolites, etc. So yeah. And is it actually known what's the optimal time point with the brain in terms of when to do the FUS and when to collect?
Yeah, we're trying to do that study in animals right now, but we have looked at some serial collections, and the increase is greatest within first 5-10 minutes so our procedure actually happens over time, right? So, but the earlier we try to collect the samples, the greater increase that we see in our samples, which is what we're really we're planning in our clinical trials, but no one's looked at that kind of systematically in a whole bunch of patients. So, but it's a study where I'm trying to do with Megan Riley to see if what's the optimal timing, and also to if if there's a animal model with two different tumors, can we sonicate one and then wait and then sonicate the other and have that spatially resolved signal from the samples.
Yeah, because like I don't know how many of our patients have Omayas, but like that maybe is something you could answer like on one of those kind of patients, right? Can you do that? Can you put the FUS thing on top of Omaya for a patient?
We haven't tried. We can probably theoretically we can block out we can create a region of no pass for the ultrasound. So basically the transducers in that area is turned off. But I don't think anyone I know of has a shunt in many of these studies.
All right, let's see if there are any other questions for Dr. Meng. So I wanted to ask you a follow-up question too about that paper that was recently published by the group, and congrats to all of you and our CNS team as well for a really nice signal there and the GBM patients. A lot of patients are asking now about how do we bring this kind of technology in a more accessible way to patients. Do you think with the better helmets, like the more portable ones that maybe other centers would be able to run trials like this, like it is still quite a barrier, I think, to access in terms of doing larger studies, right? And GBM. So where do you think this may be going with the next generation of helmets?
So I think that's why, some of these other devices are kind of increasingly adopted. So a lot of the centers I've spoken to who are interested in ultrasound or getting set up with ultrasound are gravitating towards NaviFus, which is a different company and makes that navigated system because it's less resource intensive, doesn't need an MRI, it can be set up in a clinic. I personally haven't seen, I have seen some of their publications. I wasn't super impressed with the results, but I think they have been made technical improvements. And from word of mouth, I've heard from people who are using it, they're getting more reliable BB opening in the region they're trying to target. Another reason why the implantable device is, able to recruit more patients. I think it just the resource limitations with the MRI guided system. I think for us, we would hope that it's moving towards moving outside of the MRI. I don't want to speak to Dr. Pinden's work, but that's what they're working towards, and they're making some dramatic design changes to their helmet is expected in the near future to do that, so that we would get rid of the frame and get rid of the MRI setting.
Yeah, it's great. And it's really been amazing to see how, a lot of what Sunnybrook's doing is really driving forth the research in that space. So, so congrats to you and the team on all of that. We still have time for some more questions. I don't know if anyone else on the line wants to ask anything to Dr. Meng. Okay. All right. I don't know, Ying, if you have any other final words. I see Nir is also on. Any final comments before we break off for today?
Sorry, I'm just I'm in the OR, so can't put my camera on. But yeah, great talking, and we're thrilled to be able to collaborate with the CNS group on this really only in Sunnybrook kind of work, and much more to come. I think every single aspect of this is a research program and study, as you can see, and Ying is definitely charging ahead and leading the way. So, congrats, Ying, MJ, and team.
Thanks so much, Nir, and thanks again, Ying, for this wonderful talk. And we hope that if you have any research questions or ideas that you think would be great to collaborate with Ying's team, that you will reach out to her as well. And it's been wonderful to have you as a clinical colleague, but also a research collaborator. Thanks so much. All right. Thanks so much, everyone. Take care.
Thank you.